Hi everyone, Naveen Nathan, Assistant Professor of Anesthesiology at Northwestern University. This is part one of 3 sections on advanced monitoring for the part 2 advanced ABA exam. Unlike this segment for the basic exam, this is much shorter. There's a lot more technology, machines, and physics involved with the part 1 exam. But the components related to the Part 2 advanced exam include a discussion of lasers and neurologic monitors, which we'll cover in this lecture, and then forthcoming invasive monitoring considerations, as well as echocardiography, pacemakers, and so forth. So in this lecture, we're going to start with lasers, okay? So what is a laser? You're essentially talking about photonic energy, so energy in the way of photons, which are created when you ultimately elevate electrons to higher energy atomic orbitals, okay? And this is basically individual wavelengths of light with a very specific amplitude and frequency. And the wavelength of the photon depends ultimately on the molecule used to excite, to achieve excitation within the laser. So you can use gases such as CO2, you can use stones such as ruby lasers. Gases like krypton and argon have been used as well. Infrared light that's emitted with the CO2 lasers tends to be absorbed within the first few cell layers. So CO2 lasers cause basically penetration only to the superficial structures when they're utilized in surgery. Longer wavelength lights such as the neodymium yttrium aluminum garnet or ND-YAG lasers diffuse very much deeper, producing more of a coagulation effect. They can cut through deeper tissue, deeper planes of tissue. So the lasers you should be aware of. We'll start with the pulse dye or holmium laser, used by urologists frequently to destroy ureteral calculi. So when you're doing a laser lithotripsy, they're typically using a holmium laser. The ND-YAG laser, again, as I mentioned earlier, this produces deep tissue penetration, denatures proteins without much vaporization of water. So it can be used in aqueous solutions without losing its effectiveness. And it's delivered through a fiber optic cable and also used for endourologic surgery and used for lesions, treating lesions on the urogenital tract and in the bladder, ureters, and kidneys. The green light laser is a KTP, okay? That's titanium phosphate laser. It's a frequency doubled ND-YAG, okay? Very similar to that. Doesn't penetrate tissue as deeply, but has a better cutting effect and pretty good for treating urethral strictures, for example. Carbon dioxide lasers, very, very commonly used in a variety of different surgical settings. Like I said, produces intense heat with vaporization, but minimal tissue penetration. So, for example, you can treat lesions of the larynx, like papillomas, with this laser. You can use this in ophthalmologic surgeries as well. It's limited to ultimately treating cutaneous lesions overall. When you're talking about lasers, you can't get away from talking about ASA guidelines for fires and airway fires as well. And you should review ASA guidelines in general for any of these board exams, because most often there's at least 1 or 2 questions that rely on your knowledge of these guidelines. A lot of times this relates to standards of practice that are well known to you, but sometimes you'd be surprised how they can twist a question to make it a little bit more challenging. But essentially, the ASA describes fires in general versus airway fires specifically. Obviously, with any sort of fire in the operating room, you have to stop all the flow of fuel source gases, like oxidizing gases like oxygen and nitrous, remove drapes and burning equipment, and extinguish the burning materials with water or saline. And of course, use a fire extinguisher if necessary. Pull the fire alarm and evacuate the patient and the personnel. With an airway fire, which is usually where their questions sort of target, in the past they would always generate some controversy. Do you remove the endotracheal tube first or stop the flow of oxygen first? They have since modified their questions by creating a stem in which the patient has already been extubated, and they ask what is the next best thing to do. And so it's become a little bit easier. The two options that people now struggle with are stopping the flow of oxygen or pouring saline into the airway. And by way of this ASA-derived algorithm, you can see that stopping the flow of oxygen comes first, followed by removing flammable material and flooding the field with saline. So we're going to move on to neurologic monitors. So brief discussion of awareness. Okay, memory in and of itself can be implicit, which is unconscious memory, and explicit, which is conscious memory. Explicit memory is what we're really talking about in our considerations for taking care of a patient under anesthesia. That's the conscious recollection of events, particularly intraoperative events. And overall, when you're talking about memory, what you're really talking about is recall. And so although patients may experience awareness under general anesthesia, recall of events is ultimately leads to maladaptive responses such as PTSD and subsequent apprehension and anxiety. Post-traumatic stress disorder may occur between a third to up to 70% who have awareness with recall under anesthesia. So the key thing is with recall or explicit memory. So you may frequently utilize processed EEG monitors. There's about 10 available on the market that all essentially take cortical frontal lobe electrical activity from the brain and filter it to get rid of the electrical noise and process it into a dimensionless index that gives you essentially a gauge of how sedated the patient is. These are not awareness monitors, although the proprietors would love to have you believe that. They simply give you a rough gauge of frontal lobe depth of anesthesia. Okay, and so there's been back and forth on whether these monitors truly do reduce awareness. Overall, the use of these sort of poor man EEGs, essentially what they are, may stand to reduce awareness in patients that are very high risk for awareness. So if you have a trauma patient who can't tolerate an anesthetic, something like that, that this may be an opportunity to potentially decrease the chance of awareness under anesthesia. But overall, the ASA does not recommend their routine use. Instead, encourages their use only selectively in patients in which you would like to titrate down your anesthetic to reduce maladaptive effects such as postoperative cognitive dysfunction in the elderly. Okay, so it's not meant to target awareness specifically. And like I said, 10 available units, 10 available types of processed EEG monitors on the market. No one of them have been shown to be superior than any of the others. So moving on to formal EEG. This is where you use multi-channel EEG. You're watching the electrical activity not just of the frontal lobe, but across the entire spectrum of the cortex. Overall, you need to understand whether you're using processed EEG or raw EEG or multi-channel or single-channel, the voltage generated by the brain is very small, about 100 times less than that of an EKG. So these things are very susceptible to interference due to myopotentials from muscular contractions or just general myotonicity, electrocautery, so on and so forth. Okay. The ensemble of electrodes used in an EEG study, together with their placement, is ultimately known as what's called the study's montage. There are 20 scalp EEG locations that are typically used in a standardized process, and the digital record of the voltage between any two scalp electrodes is called a channel. Okay, so no definition between a montage and a channel. Intraoperative monitoring usually involves montages aimed at recording fewer than 8 channels, but sometimes only 2 or 4. Okay, and they do that largely because they want to target the area of interest depending on what the neurosurgeon is doing territorially within the brain. So, questions about EEG that have been asked in the past by the ABA. Isoelectric EEG is obtained using a high dose of thiopental. What is the maximum achievable reduction in CMRO2, or cerebral metabolic rate of oxygen consumption? So, as it turns out, you can't get any more than a 50% reduction in CMRO2 when you give a high dose of a GABA potentiating agent to achieve an isoelectric EEG. There's only one thing that can drive your CMRO2 down further than that, and that is, of course, hypothermia. Now, which of the following EEG findings is most likely to be seen under high doses of opiates? You can read your choices here. I don't expect most students to really know the specific EEG findings with opiates. It's pretty rare to do a very high-dose opiate anesthetic overall. But in the end, high doses of opiates tend to produce delta waves. Okay, you can't achieve burst suppression or isoelectric EEG with opiates, but you can get all the way down to delta waves. Okay, the way I remember it is delta is a type of opiate receptor, so that should kind of sort of hint you along. Low-dose opiates show a loss of beta waves, which is the awake sort of rhythm, and a slowing of alpha waves. Moderate doses show diffuse theta waves, which that's sort of like the asleep, relatively asleep state, and high dose show delta waves. Okay, that's a very deep state of sleep. And this is what these waves tend to look like. Okay, beta waves have a very high frequency, short amplitude, and you get progressively to higher amplitudes and slower frequencies as you get down to theta waves and delta waves. That's the general pattern as you get to greater depths of anesthesia. And this shows you the corresponding frequencies that define these waves. So during brain surgery, neurosurgeons typically use direct electrical stimulation or mechanical stimulation of the cortex to identify muscle and speech areas. Repeated stimulation can instigate a seizure by instigating a number of after discharges. So it's only when you have someone under anesthesia that you can trigger the intraoperative seizure, because then you can put it down quickly with an intravenous anesthetic. Methotrexate is the sort of prototypical anesthetic that can wind up temporal lobe epileptiform foci. Etomidate can do that to some degree as well. It's part of the reason why methotrexate is sort of considered the gold standard for management of patients receiving electroconvulsive therapy. So EMG, so we're moving on to peripheral neuromonitoring sites. Electromyography is a continuous assessment of motor nerves by placing needle electrodes into muscles directly. So, for example, in addition, vertebral pedicle screws may be stimulated electrically to see whether they are wholly within the body when they're doing spinal reconstruction surgery. If there's a breach in the spinal canal, EMG activity will occur at a much lower stimulating current, or it may occur spontaneously even. So that's one way to use EMG probes. Electrocautery and saline irrigation are major sources of interference. You can record spontaneous activity through EMG monitoring. Okay, and that you're just looking at general electrical activity of the muscle over time. If you start to see erratic behavior, that is basically surgical trespass across the muscle, or the patient's getting light, they're starting to buck, or you've run out of your muscle relaxant, you need to redose. You can also record responses subsequent to stimulation of the motor nerves as well, and that's a more of a motor evoked potential as opposed to free running EMG. There's really no anesthetic agents that interfere with EMG responses. Of course, muscle relaxants are not anesthetics, but they are a drug class that obviously block neuromuscular junction and should be avoided during cases when you're doing EMG monitoring. So that's our segue into direct evoked potential monitoring. The basic concept is you're applying a stimulus to evoke a response. Okay, this can be either motor or sensory, visual or auditory. And the signal that you get after you apply stimulus is assessed in terms of its latency, so how long it takes to arrive at its destination from the starting point where you apply the stimulus, and the amplitude, the strength of the signal. So most sensory evoked potential amplitudes are pretty small relative to background EEG activity. And that's why you need to evoke a response with, for example, electrical impulse, and then assess the downstream effect of that sensory evoked response. Okay, again, you're assessing latency and amplitude. So with somatosensory evoked potentials, the electrical stimulus is applied to a peripheral nerve, so you're out in the periphery, and the responses are measured over the cortex with scalp electrodes. You can also measure all the way up along the trajectory of the nerve. So over the brachial plexus, for example, you can measure that latency as well as on the cortex. You average about greater than 1,000 responses to produce a clear signal. So SSE responses from the posterior tibial nerve stimulation, for example, are mediated by the cortex supplied by the anterior cerebral artery. This is an example of what you might need to focus on for the exam, because they can ask you about the basics of SSEPs, but they might put it in a very functional way. For example, if someone's presenting for an ACOM aneurysm clipping, they might ask, where in the body is evoked potential monitoring most critical? And you would identify that the lower extremities are the most critical, because the lower extremities identify the territory that the ACOM aneurysm feeds in the cerebral cortex. So, and definitely know this information in a functional way related to the anatomy. Okay. As a contrast, stimulation of the median nerve, for example, evokes responses in the cortex supplied by the middle cerebral artery. Again, a more functional description of the way you use this monitor. So, the most common definition of a significant change in somatosensory evoked potentials is a 50% drop in amplitude or a 10% increase in latency, or both. Asymmetric changes are also suspicious for some surgical trespass across the nervous territory, CNS territory. Frequent causes of false positive changes, changes that occur but without any resulting injury, include anesthetic influences, hypothermia, acute changes in CO2 tension, hypotension, hypovolemia, and anemia. All of these have to obviously be addressed and corrected, because they can have bad outcomes, of course, but it's not a surgically mediated injury to the nerve. Isolated injury to motor tracts might be missed, so unless you're using motor evoked potentials alongside your SSEPs, you may not necessarily pick up on motor deficits. Volatile anesthetic agents and nitrous are the most suppressive agents, and it's pretty difficult to obtain reliable SSEPs when you're giving more than about a half MAC of these agents. So we typically run intravenous anesthetics to compensate, which are far more forgiving. Opiates have minimal effects on SSEPs. Ketamine and etomidate doesn't really suppress SSEPs, and muscle relaxants, of course, don't interfere with them either. So overall, volatile anesthetic agents and nitrous are the most impactful drugs on this sort of monitoring. Motor evoked potentials, you stimulate the motor cortex and the corticospinal tracts of the spinal cord, relay these signals all the way down to the motor endplate and elicit a movement. So this is essentially the mother of all twitch monitors, okay? And they have to use an extraordinary amount of voltage on the scalp to get this to respond, okay? So this helps reduce the need for intraoperative wake-up tests to test muscular function. Children require stronger stimuli to elicit this motor evoked response. And overall, you want to be careful about your level of paralysis. You should probably avoid it altogether when you're using motor evoked potentials. Now, volatile inhalational agents are suppressive here. Nitrous also as well, but to a lesser degree. Intravenous agents is dose-dependent, but overall far less impactful than using inhalational agents. Ketamine and etomidate are, again, well tolerated. Gradual decreases in motor evoked potential response amplitudes occur over time under general anesthesia. It's just a generalized process called anesthetic fade. Might be due to fatigue of these corticospinal tracts or direct spinal cord influences from your anesthetic. Muscle relaxants, obviously, you don't want to use these because they completely obliterate your ability to assess motor evoked potential monitoring. So this table is from Cottrell and Young's neuroanesthesia, and it shows you what happens to latency and amplitude for SSEPs and motor evoked potentials with the use of your commonly used anesthetic medications. So visual evoked potentials, you're essentially exposing the retina to a series of bright lights and transmitting that information through the optic nerve, through the optic chiasm, back to the occipital lobe. These are technically difficult to do and extraordinarily sensitive to anesthetic agents. I mean, you're not even contacting the nerve like you are with the probe inserted into a muscle, for example, with motor evoked potentials or SSEPs. Here you're just flashing lights. And so they are very, very sensitive to your anesthetic and hard to obtain. Brainstem auditory evoked potentials, on the other hand, are very robust. If you have to know anything about evoked potentials for the boards, definitely remember that brain auditory evoked potentials are the most resistant to anesthetic effects. Part of that's due just to the very, very short anatomic trajectory between the auditory pathway and the vestibulocochlear nerve. It's pretty much a straight shot to the brainstem, and so the integrity of the signaling is pretty good. Okay, and basically, it's a series of auditory clicks that are applied, and they measure the response across electrodes placed over the scalp. Overall is a pretty reliable way to monitor brainstem anesthesia. So this is the one monitor you can use to look beyond the depth of the cortex, because this does integrate with the cranial nerve 8 nucleus, which is in the brainstem. So it's the only one that really reliably show you what's going on at the brainstem level. Again, these can be sensitive to volatile anesthetic agents, but overall the effect is minimal. Muscle relaxants have no effect. So I put this in from Cottrell's book. I'm not going to go over it in detail, but you can look at it on your own time. But it shows you different types of procedures and what kind of neurological monitors are typically used for these types of procedures in general. So it helps sort of clarify why you would use free running EMG versus motor evoked potentials versus brain auditory responses, things like that. So we're going to move on to other neurological monitors, and we're going to have a discussion about Transcranial Doppler technology, which basically calculates blood flow velocity from a shift in the frequency spectra of a Doppler signal. So, ultrasound is becoming the monitor of choice in all aspects of anesthetic care. And one of the ways you can utilize ultrasound and Doppler technology is to assess flow velocity in the cerebral vessels. And this is mostly used to assess for cerebral vasospasm more than anything else. Okay, so changes in flow velocity correlate closely with changes in cerebral blood flow, provided that the angle of insonation, so basically the angle between the axis of the vessel and the ultrasound beam, and the diameter of the vessel insonated remain constant. So one of the take-home messages here is that this is a very operator-dependent monitor. Okay, you have to do it exactly the same way every single time, otherwise you may be misinterpreting your results, and that can lead to erroneous treatment strategies. So factors affecting the flow velocity. Overall age, flow velocity in the middle cerebral artery is lowest at birth and peaks at around 4 to 6 years of age, and thereafter decreases steadily to about 40 centimeters per second during the 7th decade of life. Okay. Gender, hemispheric cerebral blood flow velocity is about 3 to 5% higher in females, possibly because of relatively lower hematocrit and slightly higher arterial CO2 tension. And hematocrit itself, flow volume is increased in hemodilutional states. So whatever your patient's current hemoglobin is matters, because the higher the hemoglobin, the higher hematocrit, the higher the viscosity of blood flow. So transcranial Dopplers can be used to assess the implications of carotid artery disease. It can examine CO2 reactivity, the detection of emboli, and the monitoring of cerebral perfusion during cross-clamping of the carotid artery during carotid endarterectomy, or testing of autoregulation. Cerebral ischemia during clamping of the internal carotid artery is probably mild if 16 to 40%, and severe if 0 to 15% of the pre-clamping value. Obviously, you're going to get a drop-off in flow, but these are sort of the rough ranges where you're trying to assess how much risk there is of cerebral ischemia. If the flow velocity of the middle cerebral is greater than 40% of the pre-clamping value, then cerebral ischemia is largely considered to be absent, and everything is considered safe. In cases of subarachnoid hemorrhage, transcranial Dopplers are unreliable measure of cerebral blood flow because of the concept of vasospasm, but it can be useful for detecting vasospasm, which is considered to be present when the flow velocity of the middle cerebral is greater than 120 centimeters per second, okay? Or the ratio between the flow velocity of the middle cerebral and the flow velocity of the internal carotid exceeds about 3. So that's where your utility of the transcranial Doppler is really going to be in play for patients with subarachnoid hemorrhage. In cases of closed head injury, you can observe for changes in flow velocity and waveform pulsatility to test cerebral vascular reserve. You can do continuous recording of flow velocity to test for the autoregulatory threshold or break point, which is otherwise the cerebral perfusion pressure at which autoregulation fails. This hasn't been a proven benefit, but one of the ways you can utilize this monitor. It does give you a rough estimate of the target cerebral perfusion pressure for treatment. Increased flow velocity with increased saturation of jugular venous oxygen levels and flow velocity ratio of the MCA to the internal carotid ratio less than 2 ultimately point to hyperemia. Okay, whereas high flow velocities in the setting of low jugular venous oxygen saturation or with flow velocity ratios of the MCA to the ICA ratio greater than 3 indicate cerebral vasospasm. So if you work your way through those values, hyperemia versus cerebral vasospasm, it should be logical to you why this constellation of findings indicates hyperemia versus spasm. Stroke. Transcranial Dopplers can help identify the source of emboli, provided that they're proximal enough. Cerebral or arterial occlusion can be identified, and you can assess for the risk of hemorrhagic transformation of large volumes of ischemic lesions. So I briefly mentioned jugular venous oximetry and jugular venous oxygen saturation. You basically have a central line. You have a catheter inserted into the internal jugular vein and advance cephalad instead of a caudad. The catheter tip is a level with the mastoid process above the lower border of C1 on a lateral neck radiograph, and you take serial samples from this line. This only gives you a snapshot in time, so you don't really do it continuously. Unless you have a fiber optic catheter, which can afford you basically a continuous measurement of oxygen saturation from the brain, essentially. Okay. Now, samples can be contaminated by factors such as extracranial venous blood, which don't come from the brain, so that could be a problem, especially if the catheter placement is too low or against petrosal veins, or if the blood sampling is too rapid. Normal values range from about 55% to 85%, and the mean is around 60% or so. Okay. Remember, your overall mixed venous oxygen saturation in the pulmonary artery, okay, is about 75%. The fact that it's only around 60% in the jugular makes sense because the brain is a very highly metabolically active organ system. So overall, calibration drift may occur, and inaccurate readings may occur if the sensor is impacted against the vessel wall or with thrombus formation, or you get a lot of extracranial blood contamination. So low jugular venous saturation values indicate either low oxygen delivery to the brain, low cerebral blood flow or arterial content, or a high metabolic rate of oxygen consumption. Maybe your patient has status epilepticus, for example, and they're having seizures. That could be a problem too when you receive low jugular venous saturation values. High values reflect a very high delivery, hyperemia, arteriovenous mixing, or a low CMRO2 in the face of high delivery. The two most common causes of jugular bulb desaturation, meaning saturation less than 55%, are decreased cerebral perfusion pressure from elevated ICP or hypocapnia. Head-injured patients, the saturation values less than 50% have been shown to increase mortality. In patients undergoing cardiopulmonary bypass for cardiac surgery, saturations less than 50% also correlated with worse outcomes in terms of cognitive function. A rise in ICP plus a normal or low venous saturation is essentially indicative of cerebral edema as the predominant cause. If the ICP and jugular venous saturation were both high, then hyperemia would more likely be indicated, and hyperventilation therapy would be the most appropriate approach forward. So jugular venous saturation is a useful technique to guide hyperventilation therapy. Your main limitation is that it's a global measure. It's not regional at all. And regional changes in cerebral oxygenation will not be detected unless it is of significant magnitude to affect overall brain saturation. So it's just not, it's a global technique. It's not one that's targeted towards the area of brain lesions of interest. Near-infrared spectroscopy. So although this has been referred to as sort of a pulse ox for the brain, it involves a little bit more than your conventional simple pulse oximeters. Overall, cerebral tissue is penetrated by light in the near infrared range, about 700 to 1,000 nanometers, and light-emitting diodes deliver that light into cerebral tissue, which is then detected by photodiodes, a receptor. The probes illuminate a volume of about 10 cc's of cerebral tissue, and the radial depth depends on the interopto distance, which is this distance right over here. Okay, a placement of the probe on one side of the forehead away from the midline is important to avoid the cerebral venous sinuses, which course right along the midline, and the temporalis muscle, which can cause interference. The reason this is a little bit more complicated than a pulse ox is that your light energy is arcing through the brain, and it's unlike putting like a probe on someone's fingernail. You're going straight. It's a straight shot from one side to the other. Here, if the interopto distance is increased, you're going through a lot more brain tissue, yes, but there's a lot more interference in between. And so this can be problematic if you're not consistent in the way you use this. Okay, and so near-infrared spectroscopy has been used with traumatic brain injury during carotid endarterectomy and neurovascular procedures. Okay. The advantages are it's non-invasive, it's continuous in real time, and there's no ionizing radiation involved. The disadvantages, the readings are restricted to a very small region of the brain. So if you can't capture the region of interest, then you're not getting very useful information. Extracranial blood flow can contaminate your reading. Okay, remember, it's arcing through the brain, so you're capturing blood that is not going through the brain. It's going through the scalp, and so on and so forth. So branches of your external carotid are going to interfere with your reading. And that ultimately relates, like I said, to the interopto distance. And increasing that distance increases coursing the light through the brain tissue and the relative preponderance of brain relative to extracranial blood. But the signal ultimately becomes weaker because there's just more interference in between. So you can reference Cottrell's neuroanesthesia textbook for a lot of this information, but this I tried to summarize everything to make it all make sense for you, and hopefully this is a reasonable summary of neuro monitors for the Part 2 advanced exam. Thanks for listening.